afternoon. My name is Sofia Gruskin, and I direct the Institute on Inequalities and Global Health at USC. And on behalf of the Institute, on behalf of the USC Law and Global Health Collaboration, the USC mHealth Collaboratory, and the USC Institute for Creative Technologies, it's my great pleasure to welcome you to Self-Care and Health, the Interplay of Technologies, Ethics, and Human Rights. Are we going back to the future, or is it a whole new world? I thought I'd begin by saying a little bit about how this event came to be. The Office of the Provost has a fund where they sponsor research collaborations amongst faculty and students working on interdisciplinary research topics across campus. And the faculty who lead these collaboration funds meet together every few months. So it was through these meetings when the groups I just noted as sponsoring this event got a chance to hear one another and to begin to question one another about our assumptions and about our ways of thinking. And it was through these interactions that the value of this kind of meeting started to become clear to us all. I guess what I'd say is that those of us who are more on the legal and rights side realized we didn't really fully understand how some of the technologies actually worked in practice. And those of us on what I'll call the more technical side had less of a focus on some of the broader societal issues that were raised by the technologies that they were creating. So we decided this event would be a nice place to begin to explore the interplay between the legal, the regulatory, the ethical, and the technological issues around the range of what can be called self-care interventions. So it's an exploration. It's not a traditional academic meeting, but our hope is that we can begin to have an interesting discussion. So in terms of self-care in general terms, what do we mean by it? Well, we're using it as an umbrella term that includes everything from abortion pills to virtual humans. And we include all of those things we can do on our own to prevent disease, to maintain health, and to cope with illness, with or without the support of a healthcare provider. Now, most people largely rely on providers for their healthcare needs, but as we've seen with COVID here in the US, this is rapidly changing. And the reality is that access to health services in this way with a provider has always varied widely within countries, including the US, and partly as a result of economic, social, cultural, political issues, but also around wealth, gender, geography, all of those things, but also government regulation, licensing, financing, distribution of resources. All of those impact who can access and who can use healthcare services. And alongside this, the scientific, the technological, the logistical innovations have continued to result in this creation of interventions that people can use themselves without directly relying on a healthcare professional or institution. So accessing and using the sorts of self-care that we're going to be talking about here sometimes is about individuals finding that interventions that they want and need from the medical system are not accessible, whether for financial, organizational, or legal reasons. So they need to access it through other means. Other times people simply prefer to access and use these sorts of services outside of more formal channels or more direct interaction with a provider. So self-care interactions can, when optimally designed and implemented, increase access for hard-to-reach populations, and to some degree potentially increase privacy and autonomy. But there's also concern that these sorts of technologies can inadvertently increase inequalities and ironically decrease the quality and availability of more formalized care systems, and particularly for the most vulnerable and isolated people in the US and in other countries. So it's these sorts of issues that we want to explore in our 90 minutes together. And organizationally, the way we've planned this session is that we're going to begin with some brief reflections from Laura Ferguson to help try to ground our thinking around some of the issues to consider when we talk about self-care. Then we're going to move into 3 brief presentations highlighting the specifics of each of the technologies alongside some very brief linked reflections. And then we're going to have overall reflections from 2 amazingly thoughtful speakers from very different perspectives, drawing on the range of technologies that are discussed. And then we're going to end with a Q&A with everybody here and some concluding remarks. Just a couple of pieces of housekeeping. So first of all, this is an exploration, so everybody has to be willing to engage and to play in the way that we're trying to set it out. Second is that we're trying to get used to this technology, so if there's any issues, please bear with us as we go from person to person. And third, and most importantly, since we're on Zoom and in a webinar format, please can you put your questions and comments in the Q&A function, and we'll get to them eventually, but the request is to please begin to use this function right from the start. So with that, let's just jump right in. And I'd like to introduce Laura Ferguson, who's the Director of Research and the Program on Global Health and Human Rights at the Institute on Inequalities in Global Health, to talk to us about self-care in general. Laura, the floor is yours.
Thanks very much, Sophia, and good afternoon to everyone. It's great to see so many people here. So I just want to start by talking a little bit about definitions and what we mean by self-care, and picking up on a few of the points that Sophia's already introduced. And you know, self-care as a concept has existed for as long as we have, but this huge growth in new products, information, and technologies is really changing what self-care means, as well as how health services are delivered. So last year, the World Health Organization, the WHO, published a consolidated guideline on self-care interventions for health with a focus on sexual and reproductive health and rights. This is the first time that WHO had published anything around self-care. And I was part of the group that helped develop the guideline. And one of the parts in the process that I found truly fascinating were our discussions around the definition of self-care and what this really means. And ultimately, WHO came up with the following working definition of self-care, and I'm going to quote. The definition is, self-care is the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disability with or without the support of a healthcare provider, end quote. I mean, that's an incredibly broad definition. It kind of spans everything from mindfulness to artificial intelligence. And again, like, look at the breadth of what we're talking about here today, from the abortion pill to artificial humans. It's huge, right? So the scope of self-care, as defined by WHO, includes health promotion. So things like apps and other digital interfaces that provide health information. It includes disease prevention and control. For example, self-monitoring of blood glucose levels for people with diabetes. It includes self-medication. So that could be taking an Advil when you've got a headache. It could be self-injection of contraceptives. It could be self-injection of hormones, whether for fertility management or gender affirmation. It includes rehabilitation, palliative care, and crucially, it includes seeking healthcare if necessary, right? So it encompasses interactions with health-related technologies and things that we can truly do on our own, things that we do for others, things that others, including community health workers, might help us with, and ultimately our health-seeking behavior. And I suspect this definition is going to continue to evolve, but it will remain expansive given the breadth of interventions that it covers. So the implication of that is that to get into the real detail of self-care, we may have to talk about individual interventions and specific contexts and populations. And this is certainly critical to ensuring that interventions are designed, delivered, and monitored in contextually appropriate ways. And context matters, we know that. We have to ask if self-care interventions are available to all those who need them, rich or poor, literate or not, whatever their gender, ethnicity, sexual orientation, I could go on, right? I come at this, most of my work around these issues is in low-income countries, and that raises real questions around who has access. How should the interventions, such as the ones that we're discussing today, be made available in these settings? Sometimes health systems are weak, access to health information is limited, gender norms are unequal, some groups face very real challenges accessing health services. So how can self-care best be implemented to reach everyone, including the most marginalized in these settings? Sophia's already mentioned COVID. You know, we know that health systems are overstretched already, particularly in the time of COVID. And self-care interventions can be a way of trying to alleviate some of that burden. And WHO is strongly advocating for the use of self-care interventions right now to help ensure the continuity of access to services in the pandemic. And I think that's really important, but at least equally important, self-care can be empowering, right? It allows us to take charge of our health, of maintaining our health, of improving our health. And alongside that, there are caveats that are really important. Self-care must be seen as a complement to the health system rather than a replacement for it. It's critical that people be provided sufficient information to make informed choices about whether or not, when, and how to use self-care interventions, and that linkages to the formal health system be available and accessible wherever they might be needed. So self-care interventions, they are a real opportunity for reaching these hard to reach populations who may be reluctant to access health services for whatever reason. But we have to make sure that safeguards are in place so that these interventions are not only accessible, but also acceptable and of good quality, and that there are clear lines of accountability. You know, there are really important questions around, you know, who's responsible if a woman gets pregnant while using a fertility monitoring app as contraception, right? Or if someone experiences severe side effects from any of these interventions and they can't access support, or if data from a digital intervention are hacked, right? These are very real questions, and they implicate a range of stakeholders, right? So a lot of us, when we think about self-care technology, we think about the technology, right? But self-care interventions are not just about technology and health systems, they also require attention to broader legal and policy environments, to gender norms, to human rights, and to ethics. And that's kind of, those are some of the issues that I think it's going to be really important to try and pick up on today. So just to say, this is an immensely exciting field. It's a really dynamic one. I'm thrilled that we have such an amazing range of speakers here today and all of the participants. And I really look forward to kind of unpacking this all a little bit further. Thank you.
And thank you, Laura. That's super helpful. Really, really appreciate it. Let's move to our first intervention, where we're going to begin to think about abortion pills within the framework of self-care. And my pleasure to introduce Francine Coteau, who's the co-founder of Plan C. And we'll go directly from Francine to 2-minute reflections from Do Mayer from the School of Cinematic Arts and a longtime champion of women's health and rights, and from Laura, who you just met. And so, Francine, the floor is yours.
Thank you so much, Sophia, for inviting me. I personally, I think highlighting the case of abortion technologies in the seminar at the intersection of technologies, ethics, and human rights was brilliant. I think probably the only more timely example of a very simple technology that has the potential to be transformative and is being politicized would be masks for COVID, right? So back to abortion. Not only is access to safe abortion one of the most hotly contested human rights, precisely because of ethics, but more pertinent to today's discussion, we are witnessing the advent of a new, simple technology that is putting the power of decision and competency directly in the hands of people who need it. I'm referring to abortion pills. I'm going to hold them up here. This is how simple it is. A combination of 2 pills that taken together effectively and safely terminate pregnancies as late as 11 weeks gestation, which, as an aside, in the US accounts for 80% of all abortions. This simple and elegant little technology provides the means to address 2 of the oldest global public health challenges. 1, to reduce the morbidities and mortality associated with pregnancy termination, and 2, to ensure equal access to safe abortion and the human rights of equality, autonomy, self-determination. The power of these pills to reduce the health risks associated with abortion lies in their safety, effectiveness, and ease of use. Regarding safety, tens of millions of women and people who wish to terminate an early pregnancy have safely used these pills and are now included in the World Organization's list of essential medicines. I'm just going to take a moment to say that when I use the word women, I also mean to include anyone who can get pregnant and who needs access to abortion. I may slip at times and use women, but I mean anyone who has the need for this. As for the effectiveness, medication abortion using pills has proven so effective that it's now seen as effective as surgical abortion, so much so that 90% of all abortions in Europe are done using pills. And most importantly, data now shows that self-managed abortions, where the pills are obtained at a pharmacy or online, are as effective and as safe as when provided in certified health facilities. So this brings me to the ease of use. As you can imagine, given that the treatment entails simply swallowing one pill, followed 24 hours by 4 pills, the process can now be self-managed, no longer dependent on access to doctors, clinics, hospitals, and all the many ways in which the access could have been stopped. Self-managed abortion is one of the oldest expressions of self-care in history. Historians have documented all sorts of uses of remedies to regulate periods and terminate unwanted pregnancies. But until very recently, taking matters into one's own hands entailed using methods that carried tremendous risks. Health risks, including severe morbidities and all too often death, and legal risks, risk of prosecution, prison, and again, in some cultures, death. The ability to demedicalize abortion pills, putting the technologies in the hands of users, has been a key to addressing access to safe abortion in virtually all parts of the world. There are amazing stories I can tell you about the history of this movement. I don't have time right now. I can in the questions. One is the story of women in Brazil in the 1980s who basically discovered this. Another is the story of Rebecca Gompertz, who last week was named one of the top 100 most influential people. So I urge you to go to Time Magazine and look her up. Here, I'm going to end by just saying that I just suffice it to say that by using the technology of the simple pills, the telemedicine technology, the technologies of online provision, the technology of being able to global markets, all of these technologies come together to mean that now hundreds of millions of people literally around the world are able to safely practice the autonomy they deserve. So I look forward to a further discussion, but let me end by showing you a very brief video. It's only a minute and a half, and I will be within my 8 minutes, that describes the political situation we face in our country and the ways that our government has managed to restrict access to this technology and restrict information about this transformative new opportunity. So if I may now switch to the quick video, that's what we're going to do. Thank you.
Our country is in a choice crisis, with an administration that's closing clinics, punishing providers, and effectively demanding people carry unwanted pregnancies to term. We need an option for a safe, self-managed at-home abortion, a Plan C, and this solution exists, so why doesn't everyone know about it? Let's review. 30 years ago, a combination of pills was discovered to effectively end an early pregnancy. The health community celebrated. The world would be forever changed. The French Minister of Health even declared them the moral property of women. But when the pills came to the US, they were severely restricted by the FDA, not for medical or safety reasons, but because of politics. Today, they're used by millions worldwide every year and backed by mountains of data on safety and efficacy. While in the US, they're still held from us by the FDA, over-medicalized, even kept out of pharmacies. But this is changing. Abortion pills and information on how to use them can now be found on the internet via online pharmacies, human rights organizations, and a physician-supported site called Aid Access. All of us can play a part in bringing this option into the mainstream. 1, demand the FDA remove the restrictions on abortion pills. 2, spread the word. Tell everyone you know that abortion pills and information on how to use them are available online. 3, know your rights and risks. Free legal support is always available. The solution is here. Learn more at plancpills.org.
Thank you, Sophia.
Thank you, Francine. Okay, can I turn it over to Doe, please?
Sure. Hi, everybody. It's a pleasure to be here. I'm assuming this technology is all working great and you can all hear and see me. I have to start by saying this is in such a difficult time with so much on all of our heads and all of the pain and stress of the moment. There is really good news in this issue about this Plan C. This is really a change of massive proportions. And ironically, although Francine didn't have time to go into all of it, COVID has made it easier in some ways for women to get access to these pills. I won't go into all the details of it, but doctors, for instance, can now prescribe across state lines where they couldn't before. All of this is done by mail, which of course in this time of COVID has really helped to make it much more significant and easy to deal with than pharmacies, et cetera. This is a technology that has totally changed the field of family planning, which I've worked in for most of my fairly long life now, and really added an addendum to it that allows women to make a choice for themselves that they can control. And, you know, as I say, in this terrible time, it's great to have some, I think, wonderfully good, safe, effective news about a technology that really can get over many of the barriers that we've had through the political systems to this in the past. So we should celebrate every happiness we can get these days. And this seems to me to be a wonderful gift to society. And I'm so pleased to know more about it. And my colleague and friend Francine has been at the head of it for years. So my unbiased opinion is I'm thrilled.
Thanks, Do. Let me just add on to that as well. And I kind of want to end there because it's such a happy, like, uplifting note to end on. I feel like I'm not going to follow that trend, I'm afraid. I do think it's an amazing technology. And I think this is, in a way, it brings to the fore why the kind of cross-sectoral collaborations are so important, right? Because we have a technology we know is safe, we know it's effective, and yet there are these political challenges and there are these practical challenges. And I think the progress that Do just flagged about what's happened in this country in recent months is amazing, right? But we also know that in many countries around the world, the law still needs to change. We know that in many places where the law has changed, people still don't understand that the law has changed. So health workers are still reluctant to prescribe because they don't know what their liability is. And women may be either unaware that the technology is available or still unsure of what their legal liability might be. So it's one of these things that we've got a phenomenal technology, and that's our starting point for now. Let's work with the political economists, let's work with all the health communications folks, Do, that's you, and let's bring in everybody across sectors to make sure that the technologies can be made available to all of the people who need them, by figuring out what the non-technology barriers are to making this really possible for people to access around the world. So I think we've come, you spoke about the demedicalization of abortion pills. I'm trying to move us into the depoliticization of abortion pills, and I feel like that may be the next frontier here, and it's not a small one, but I think we have to rise to that challenge, and that will help move us forward for greater impact on women's health. Thank you.
And thank you to the three of you for our first little mini case study, if you like. We're going to now totally switch gears, I think. And we're going to be looking at Ask Ari, which is an informational tool that's used here at USC, which is going to be presented by Lyndsey Christoffersen, who's a project specialist, campus wellness, wellbeing and education, and Eileen Rosenstein, associate vice provost, campus wellbeing and crisis intervention. And then that will be accompanied by two brief reflections from Charlie Kaplan, who's the research professor and interim associate dean of research at the George Peck School of Social Work, and then quickly from me as well. So with that, Lyndsey and Eileen, I'm not sure how you're doing this, so go.
Sure.
Go.
Thank you. So for 18 years, I was the director at University of Pennsylvania's counseling service. My background is clinical psychology. And then I came here to USC, and for 9 years, I was the director of the Student Counseling Center here. And what I found was that about 1/3 of our students needed therapy, needed to see a counselor at some point. And we just didn't have, with a population of 40,000, we were looking how to handle this and manage this. And one of the issues that really emerged was that often students, young adults, didn't know when to come for professional help, that was a real challenge. How do they know that counseling would be of help to them, and that their symptoms were serious enough, or their conditions or their experiences were such that they need to come? Another third really kind of knew about self-care, but they had internal and external barriers to getting that health care. Part of it is time. As you know, students are very busy. Some of you in the audience are students, but some of it was also other things that were either internal in the way they assumed about health care and self-care, and others were external, that really how their lives were structured. And then finally, there was another third of students who basically, if they got the information, they were able to put them in play and implement. The difficulty with that is that they weren't always getting evidence-based treatments, things that we knew that really worked. So we developed Ask Ari, one for the scope to make sure that people can use it. Students from all different socioeconomic class have smartphones and are able to use this technology, and that we really wanted to help to get people to the right resources and to have the kind of self-reflection which this technology allows us to do. And I'm going to turn it over to Lyndsey, who will just kind of briefly show and demo the product.
Hi, everyone. Great to be here today and see all of you. Oh, my air conditioning just bumped up, of course, right when I unmuted. Hopefully you can hear me. So I'm going to just give a quick demo of the actual Ask Ari system that is live for you and available for USC students. Let me share my screen. So let's see, do full screen so everybody can see it. So this is the Ask Ari system, and it's based on really what Eileen was talking about, which is education for students. Students are looking for information and having, getting random YouTube sources or blogs or things that are not evidence-based. And so we wanted a curated place for our students to be able to get this information, because people want the information. It's just sometimes difficult to find, or, they want the legitimate evidence-based stuff, but in addition to school, you don't have time to read, 18 medical journals to figure out what's going on with your issues. So what Ask Ari does is it engages individuals in a conversation and helps them self-reflect through AI. So I'm going to start it. Let me move my Zoom screen so I can see everything. Okay.
Hi, I'm Ari, Wellbeing Wisdom in Your Pocket. I'm here to help you thrive by leading you through some evidence-based self-reflection activities and connect you with USC resources. Your privacy is very important to me, so please know everything we talk about is confidential. I recommend you check out the topics menu to find out my areas of expertise and what other students frequently ask. You can interrupt me anytime by typing into the chat box. If you see the next button, it means I have more info to give you. You can control our conversation pace, input, and audio with the controls on the bottom right. I will also suggest some related topics throughout our chat. Click on the links to go straight to them. Emergency information can be found in the emergency section. This program is for informational purposes only and not a replacement for a medical doctor, therapist, or a reporting mechanism. Now, what would you like to talk about today?
So what's great?
I'm Ari. Wellbeing Wisdom in Your Pocket.
What's great about this is I can mute Ari if I don't want to listen, or maybe I'm talking to Ari and my roommate walks in and I'm asking about questions of sexual orientation or stress or family issues, those very personal issues that maybe I'm not comfortable about talking with a human with yet. And so Ari gives that option of being able to turn your mic on, your mic off, read it and engage with it in a few different ways. We also have an app version that students can download on their phone. So what most students do is they type in "I'm stressed" as the first thing, or probably what most of us would do at this point. And what Ari does is, again, I've Ari muted right now just so I can explain some of the features, is normalizes it. So anxiety is a normal thing, and instead of it being something that you should control or fear, realize that it just means you probably are really, you want to do well in school. You want to, succeed. And so it's not necessarily a bad thing. But if you're having problems with it, here's some different tips on the ways that you can deal with stress and anxiety, and some quick tips. And so we try to engage in a number of different ways. So through audio, infographics, video. We have guided audio from Mindful USC, which is one of our partners on campus. And then Ari suggests other topic areas related to this topic so they can dig a little deeper. And then also there's a number of frequently asked question menus over here, which is great because a lot of students will go in, ask a question, and then kind of like check out what else there is. So if I'm stressed, oh, look, I can check out these quick stress management techniques, all these different things. If I'm not, I don't know what grounding is, so maybe let me give that a try and click on it. And my Wi-Fi is a little slow, so sorry about that. Ari again explains what grounding is. I can skip ahead if I don't want to wait, for a conversational tone. And then we're given guided audio for different grounding techniques that students can use. I know I always love the sound of that bell, it just calms me down immediately. So getting ready for a final, or maybe you just got in an argument with your significant other and you have to focus on this paper, but you're thinking about those emotions, you can ask Ari and pull up a grounding technique to immediately deal with the stress management issues. And then maybe I have a more specific issue. So I'm stressed about, and we have them categorized by different areas that students have commonly asked about: academics, drug use or cigarette use, things that might give students chemical-based anxiety, or something like my weight. And I think that this really highlights kind of the capabilities of Ari and the point of Ari, because if you look at this, students are given information, but they're also referred out to on-campus counseling. So if weight is dominating your thoughts, that might be a concern and you should probably make a counseling appointment. But if it's just something that you're thinking about and you're stressed about and it isn't a huge concern and you want help with it, OT has a great Design Your Life program that can help you with this.
1 minute,
and then
please.
It suggests other areas, so like cognitive distortions, which is a type of unhealthy thinking, because it might not even be an actual issue. It might just be you have unhealthy thinking about yourself. And so there's a lot of different ways we try to engage with the students. We have assessments. And I think back when I was in grad school, and I think like the main thing we had was, grad student support group, which is great, but it was like every Wednesday at noon. And sometimes it's Friday at 7 and you're freaking out over your work and you want help then. And so being able to take a flourishing skill and see what you can work on in the meantime, do a grounding technique, and see how that, works for you, and do those sorts of things can be really helpful.
I think this is an exciting presentation, especially for the USC students. We know all of the really serious problems with suicide on campus that has been going on for a long, long time. And the access to mental health services has to ramp up. And this is a really great step and an example. And I was very happy to see right from the get-go the limitations are set. That is the principle that we first mentioned, that self-care is not an alternative to the health system. It's really a complement. And it's not saying, well, you can take Ari and take it home and now you have your therapist in your pocket and you never see it. That's set right from the get-go. And that's the basic principle we're talking about right at the beginning, that self-care is much more than technology. It's all of the background that Laura mentioned that needs to be taken in consideration. So while artificial intelligence is good, we know from the neurosciences that we have many kinds of intelligence. We have cognitive intelligence, but we also have emotional intelligence. And so the emphasis on self-care and almost like in old psychoanalysis, the idea is that really the patient and their friends cure themselves, and the psychiatrist at that point is really a guide to the self-care. So there is sort of it's been used different ways, but this basic principle of a partnership between the healthcare system and the patient that can take care of themselves and live with it and learn how to cope with it with their friends, their lay therapist, is very important. And this sets the stage for it. So that's my reflection.
Thank you.
I have to stay on time, and I gave myself a timer just to make sure.
Thank you. Yeah, I mean, I think from my perspective, I mean, as we think about the ethical, the rights, you know, the legal, the policy issues for these sorts of interventions, right? I think for me, there's an issue about the information that's provided to the user through these sorts of apps. Like, who makes that decision about what information is provided? The decision about what to collect, to the way that the information is collected, the way it's disseminated, the way that the data are held. And I think there are questions about what this means and how the users understand what this means in terms of the data that are generated, how the data are collected, and that this can help us to think about maybe what appropriate data systems look like. I mean, it's not at all to question the value of the technology. The value of the technology is super clear, but it's a question about how we ensure that the data, that the uses of the data are appropriate, lawful, ethical, but also sensible. Like, who decides and according to kind of what criteria? And I think one of the questions is it like at the larger government level? Is it the university? I mean, is it USC in terms of being able to put that in place? Is it the students who are the users? Is it the creators of the technology? You know, like, where is responsibility in terms of trying to ensure that the data generated are used in an appropriate manner? And I hope, like, it's something we can explore further later. Again, it's not about Ask Ari, it's about kind of the bigger questions that it opens up. So I now switch back into kind of moderator mode, because those were my brief reflections. And if I can now turn to Bill Sordat for our final presentation. Bill is the co-director of the USC mHealth Collaboratory and Chief Technology Officer for the Institute for Creative Technologies. And he's going to present Ellie, a virtual human. And then we'll have reflections from Donna Sprout-Smits, who's also co-director of the USC mHealth Collaboratory and professor of psychology at Dornsife. And then from Alex Capron, who's university professor, and Scott, vice chair in healthcare law policy and ethics. So Bill, the floor is yours.
Great. Okay. Well, thank you very much, Sophia. I'd actually like to share my screen here, give a little overview really about some of the work that we've done on virtual humans generally, and then I'm going to focus more specifically on a particular one called Ellie. So the vision that we have for virtual humans is ultimately we would like to be able to create computer-generated characters that look and behave as much as possible like real people, and that are autonomous. They're thinking for themselves. They interact in a fluid, natural way using both verbal communication as well as nonverbal communication, things like gestures and appropriate head nods and eye glances and that sort of thing. And importantly, not only do they act intelligent, but they also do things like exhibit emotions, because basically being emotional is an integral part of what it means to be human. Well, so this is a great goal, but really, why are we studying these virtual humans? Well, I think for me at least, there are two reasons. One is virtual humans really represent a new metaphor for interacting with computers. We're all familiar with the desktop metaphor with its Windows, mice, and keyboard for interacting with computers. Well, here you're basically presented with a virtual human that is your interface to a computer system. So in a sense, the computer goes away in this example. And it's possible with virtual humans to add previously missing social elements to an interaction, things like building rapport. And we've shown that this is possible with virtual humans, creating excitement or passion about a topic and adding in social cues and that kind of additional information that is typically missing in the kind of cut and dry interaction with a conventional computer. The other thing is that virtual humans really help us understand human behavior better, because to make them work, you've got to create operational models of reasoning and emotion and communication, perception. And I would argue that perhaps building a successful virtual human is the ultimate test for artificial intelligence. So I want to skip ahead here and just mention that we've built a large number of virtual humans, and actually some of the virtual human technology that we created was used in the Ask Ari system that was just presented, that Lyndsey and Eileen presented so nicely. I want to focus now on a particular virtual human. This is one we did a few years ago, called, the project was called SimSensei, and the idea was to build Ellie, a virtual intake nurse. So essentially, this is the person that you talk to before you see the real doctor. And the idea was to interview people looking for signs of PTSD or depression. And Ellie has a very rich perception of the person that she is interacting with. So it's not only sensing the voice, what they're saying, but also picking up with computer vision, body position, facial expressions, a whole range of things. And those are then synthesized using machine learning techniques to come up with an idea of how is this person feeling. And so here is a demo of what it's like to interact with SimSensei. On the left, you see the sort of the computer innards screen that shows the person that's interacting, how their face is being tracked, measures of their body activity, gaze attention, things like that. And on the right, you see the actual virtual human that the person interacts with.
Hi, I'm Ellie. Thanks for coming in today. I was created to talk to people in a safe and secure environment. I'm not a therapist, but I'm here to learn about people and would love to learn about you. I'll ask a few questions to get us started. And please feel free to tell me anything. Your answers are totally confidential. Are you okay with this?
Yes.
So, how are you doing today?
I'm doing well.
That's good. Where are you from originally?
I'm from Los Angeles.
Oh, I'm from LA myself. When was the last time you felt really happy?
When was the last time? I don't know. Yeah, I'm not someone who's really like, I don't have any real highs. I feel like I'm a level person. It's just happy. I guess to answer your question, probably a couple months ago.
I noticed you were hesitant on that one. Would you say you are generally a happy person?
I'm generally happy. It's just lately there are things just keeping me down.
Can you tell me more about that? When was the last time you felt really happy?
But I try to stay happy. I'd rather be happy. My kids keep me going.
What advice would you have given yourself 10 or 20 years ago?
To not believe, to not be so gullible, to not be so gullible.
Mm-hmm.
I've been told recently that I have a tendency to believe people too readily without them having to prove anything. And so as a result, recently I've gotten myself in a lot of trouble. And so I think that looking back, if I could have, I would tell myself to not believe, to not be so stupid, and to think, and just to not be so gullible.
So one of the things that shows is that the character is actually responding to how people are interacting with it and pressing in when it seems like there are issues to be addressed, and moving on when it looks like something is not an issue. So the system is very adaptive and is using its dynamically formed hypotheses about what's going on with the patient to figure out what to do next. But an important question that we had to deal with is, how are people going to respond to virtual humans? And particularly, do they respond to them like they do to real people, which is often the case, but there are some important differences. And one of the things we found with the Synsense project was that people are actually more willing to disclose sensitive information to a virtual character than they are to real people. And we did actually a study that looked at that question explicitly and found that that was in fact the case. And so the potential here is that you can have a virtual system that is going to be more successful in getting sensitive information out of a person because they don't feel like they're being judged in the same way that they feel like they are when they're talking to a real person. And so this is really an interesting kind of new capability that this use of virtual technology presents us with. But this also raises, I think, some important ethical issues, and I'm going to leave that to the discussants to talk about maybe. So thank you, and I would like to pass it on to back to Sofia now.
Great, thanks. Donna, for your set of comments.
I'm ready. So I love these virtual humans, as Bill knows. Some really interesting ethical issues come up on the plus side and on the minus side. On the plus side, I think also seeing the earlier Ask Ari presentation and some of what Eileen told us, we can't keep up with healthcare's demands on our very wealthy USC campus. So look, in the rest of the world, they're just, in the mess that our country's in right now, we certainly are not keeping up with healthcare demands. So virtual humans have an enormous possibility of impacting that, of taking the burden off what the scarce care, of offering sometimes better care. I would like to mention COVID right now for people at risk who don't want to go into the doctor's office. Virtual humans are an attractive and excellent way of providing care and providing advice. So I think that there's a lot of room for these in the world. On the minus side, people, we are so gullible. We forget in 2 seconds that we are not talking to a real human being. It's kind of great, but we are not talking to a real human being. And the virtual humans have their limitations. They can only take a discussion so many layers deep. They are limited to what's been programmed. and they are limited to what's been programmed and limited by who programs it and the beliefs of that particular entity or person. They're often built, the programming is often built up on what we call skeuomorphism. So something is built into the programming on the bottom line, and then some new programmer comes in and error after error gets programmed on error after error. So things can go south with a virtual human because the virtual human might give the impression of authority but might not have it at all. And I hand it over to Alexander Capron.
Thanks very much, Bill and Donna, for that. I want to begin by taking off from a point that Donna touched on, which is the much increased use of virtual or at least online interactions in the COVID era. And I want to start by asking, why do we think that wasn't more prevalent before? And the two obvious, well, three obvious explanations were, the first is the system really wasn't set up to support it very well. The second is patients or clients may not have wanted it. And the third is that the resistance to it came from professionals who either did not think that they would be valued if they were not engaged in this process, or simply didn't feel trained to do the kinds of interactions that would be occurring online. They lacked the expertise. Now, if it is the latter, that it's the professionals, then we should have to think of this as a barrier, and we could very much see why virtual humans are part of our self-care discussion, which is a way of saying, how do individuals get what they need without depending upon a system that isn't responsive to them? Some years ago, I, within a process of a period of a couple of years, renovated 2 houses for myself. I'm not in the business of renovating. And I, in the first time, I used a cabinet maker. It was a company, but it was basically custom-made cabinets by human beings, measuring things out, cutting the boards, building the cabinets. And the second time, I used cabinets made from Germany that were all made by machines. And the difference was that the former had all the little quirks that human beings bring to a project, and the latter was absolutely perfect, but of course was perfect whether it was made for me or for anybody. There was nothing about it that was particularly responsive, and there were limits to what the computer could do, whereas the individual cabinet maker could do anything. And I mention that because if we're thinking of self-care in access terms, we are thinking that it will increase access, and that's great, but are we at any risk of it being part of a 2-channel system in which some people get access to living beings and some get access to a virtual, and it becomes a 2-class thing? Now, we've seen enough about the value of LE and other like simulations to know that the latter isn't necessarily bad. Those German cabinets I got were perfect. They didn't have any flaws. They were measured exactly as described. But that doesn't necessarily apply to all these things. And Donna pointed out one thing I want to emphasize. It's not just the process of iterations, it's the underlying information that goes into these programs in the first place. And we know that a lot of the data on people has implicit biases built in because those data are created by us in our own existing interactions, which are far from perfect. And so we can get into a situation where the machine person is simply reflecting those biases, but doing it in a system that we think, because it isn't personal at that point, would be free of biases. We don't have an individual human introducing new biases, but the rest are built in. Finally, I want to ask the question whether the benefit that Bill mentioned that, and that I think Donna reflected, which is that you forget you're talking to a machine. Do I want to be in a world in which I don't distinguish between machines and human beings? I'm not sure what the answer to that is, but I know for me it is a puzzlement. Thank you.
Thank you. Thank you all for that. I'd like to hand it over to Donna, if you would, to introduce our two panelists and to moderate our collective discussion. Thanks.
All right. So it is my pleasure to introduce Peter Anyanev. Peter, excuse me, my husband has just walked in. So Peter Redfield is a Robert F. Airburu Chair in Ethics, Globalization, and Development at USC Dornsife, and he's an anthropologist by trade, if I'm right, and I'm very excited to hear him talk. And then my friend Yaniv Bar Cohen is a co-director of CTIP, which is Southern California Consortium for Technology and Innovation in Pediatrics, and also a doctor par excellence, who's done some really innovative work at Children's Hospital.
First, I'd just like to thank everyone for presenting such interesting material to think about, because this is an extraordinarily timely discussion given the pandemic moment. In the past few months, I think many of these issues have only more come to the fore. And so while questions of self-care are very old in a sense, much older than professionalized medicine, obviously, and a near universal experience, there are newly relevant and also newly pointed in terms of thinking about questions of policy. And there are a couple of broad general points I want to make, but even before that, I would like to note that it's always very difficult to try and think critically about those things that we like or those things that we consider to be good. It's much easier, broadly speaking, to think critically about things we dislike than things we're in favor of. So the first of the two thematic points that I want to emphasize here are, the first one is, what concept of the person are we presupposing when we're discussing self-care? And with this, I'm just returning to a classic theme from medical anthropology, which in thinking comparatively, broadly speaking, about human history and different human societies, many of them have understood the person, the self, the being, to be much more relational at its very core and in its very nature than to be an atomized individual who only subsequently acquires relations in society. And thus, both the self and also health would be understood through relationships, which could also be healthy relationships or pathological relationships, not just individual psyches or individual bodies. And so in terms of thinking about these relationships, I would also note that it's actually humans have long dealt with non-humans as other kinds of possible persons to engage with in the world. Animals, as well as others who we recognize as being humans. And more recently, it's not a surprise, we have robots, we have different kinds of algorithms and avatars that we can respond to. And if you start thinking in terms of the history of human religion, this is also not so surprising, because people have long talked to divinities. This is what prayer is about, the kinds of appeals that you can make, the kinds of different forms of engagement which you can undertake when you think something is amiss in the world and you're trying to set it right. I would also note that assumptions of the person that frequently are built into these discussions, legally, politically, technically, are that this will be an individual who is capable of rational thought, who will be self-governing, and will be able to respond in predictable ways when seeking care. This tends to be the baseline assumptions of what a person would be. So I would stress one thing in relation to this thematic point, which is that when we're thinking about access to care, we should be thinking about not just access to materials or to forms of knowledge, or even to expertise, but also to relational being, access to being able to be with others in ways that we would conceive of as being healthy, as opposed to being pathological. The second theme, which I just want to point to and quickly note, and this reiterates some things that Sofia and Laura and some others brought up earlier, is the question of how does a focus on self-care stress users as opposed to experts? And therefore, how does it affect received politics and ethics of how we try to manage care and ensure that care is well delivered and delivered in a way that we would like to see. And so it raises questions about education, regulation, and accountability, for which we all have systems worked out legally, and we fight over them politically when it comes to professional behavior. This would be the line between what is practice and what is malpractice in terms of any moment of engagement around health, say. When we're talking about users, we have to remember that users are trained primarily through use rather than education. There may be instructions to any given program or a little advisement at the beginning of a session that may or may not actually shape a user as much as repeated practice, as doing the thing over and over. And users may or may not conform to assumptions of designers. This is something that's well known in the history of technology and in the study of design and so on. Users can have different expectations, and they can also prove creative in terms of what they do with any object or system. They may not use it according to the instructions. They may deviate from them, and they may also create things with this. This is why our phones are so much more complicated than phones these days, with layers of human practice built into them. Now, when is this a good thing and when is it not a good thing? Who bears responsibility if things goes wrong? Who is responsible for maintenance beyond innovation, of making sure that a system continues to function the way it is intended to function? Who draws a line between what constitutes practice and malpractice when it comes to technologies which are meant to enable self-care, particularly in contexts of global health, I'm thinking, where funders rather than patients are often the targeted consumers, that rather than being as a patient consumer-driven model, it's a model which is filters through forms of humanitarianism, charity, government aid, systems where the people who are making decisions are not necessarily driven by the same market pressures as we like to imagine within a market, functional or dysfunctional as it may be, as in the context of the United States. So the second broad thematic point I just want to make in closing is that self-care can reconfigure ethical and legal questions about responsibility. And that in thinking about technologies, we need to be thinking about the forms of society and the forms of politics which they enable and which shape them as they move through us and around us and in the world. So those are my meta points, and I look forward to general discussion about this wonderful set of interventions and this topic. Thank you.
Thank you so much, Peter. Before I hand it over to Yaniv Bar-Cohen for the last overall reflection, I just wanted to remind the audience that after Yaniv's reflections, we will be opening it up to questions and answers from the audience. And so use the Q&A button at the bottom of your screen, type in your questions, and I will be talking to you about them. I will be asking the panel about them after Yaniv's remarks. Okay, and now I hand it over to Yaniv.
Hi, everyone. So I'm going to give a few reflections based on my own experience as a physician and someone who works a lot in the technology space. And I guess my first disclosure is I'm actually very excited about self-care and the potential for self-care. I think all of the talks today have been very thought-provoking, very exciting. It's very easy to see a better world. So that's my disclosure, which probably lets you know that that might not be the only opinion I have about this. And in fact, what I want to focus on is potentially some of the things that I, as a physician, and especially someone who works with technology, am very concerned about in relation to self-care, and then ultimately end with why I'm still very, very excited about what this is going to bring in our future. So as I think about self-care, I basically break what we do with self-care into two categories. One is diagnostic and one is therapeutic. I think some things are a little bit of both. Mental health, for sure, is somewhere between diagnostic and therapeutic. I would say in general, I'm very excited and I'm less concerned about the therapeutic side. It is hard to not be excited about the potential of something like Plan C. It is hard to not be excited about occupational therapy and physical therapy, things you could do on your own using technologies that require very little healthcare professional assistance, and how that can help society. And so I'm going to focus less on the negatives of therapeutic and really focus on the negatives of diagnostics, and potentially the positives as well. So self-care and diagnostics is actually a really big part of where technology fits into self-care. There's so much to be excited about. The idea that some machine at home can look at your eyeball, see in your retina, and tell you have diabetes or tell you you're at risk of heart disease, that is exciting. The idea that a stethoscope at home can help your kid manage asthma, that's exciting. The idea that you could check your EKG at home and tell you if there's a problem, that's exciting. Ask Ari and everything around that, that is all very, very exciting. And I'll give you a very great example of why self-care can be good. Let's take an Apple Watch that now can check your EKG. Someone has this watch on, they don't feel great, they push a button, it tells them they have a very dangerous arrhythmia, they call their doctor, they go to the ER, they get treated, they get cured, and they're basically gonna be great, and if they didn't know this information, they might have died. That, I think, is the story that we think about when we think about the wonderful thing that is self-care. But I will tell you from my own experience, where we are in 2020, that is not how self-care looks with diagnostic devices at home or anything at home that involves diagnosis in many cases. First of all, let's talk about who is the person who uses self-care in this way. It is often not people who don't have resources, who struggle with access. It is often people who have various, let's say, anxieties about their health. Okay, it is let's take the 25-year-old who feels palpitations while studying for an exam at school. That person then says, well, I could go see a doctor or I could go buy this device to figure this out. And a lot of times that's what they do. They either already have a device or buy a device that helps figure it out. And sometimes they're told everything is fine. A lot of times they're told, oh, actually there may be a problem here. And that problem, no device right now, no technology, no self-care that involves diagnostics is going to take a chance of missing something, right? Whether it's someone who could potentially commit suicide, whether it's someone who has a dangerous heart problem. So the threshold to say you need to contact a medical professional is very, very low, and that's what happens. Person will have the device, it'll say they have potentially a heart rhythm problem because they have palpitations, and they will call a doctor. Now, many people on this call have already mentioned that we don't exactly have an abundance of healthcare resources. So now we're talking about tapping into an already difficult healthcare system to try to answer a question that feels urgent. Someone might have a heart problem. So they see the doctor. The doctor looks at the same information that is generated by that machine and says, actually, I'm not sure there's a problem. Or let's do a few more tests and try to figure this out. In the meantime, I don't think you should exercise. And it'll probably be okay, but let's just see how this works out. Ultimately, a lot of tests are done, a lot of anxiety is provoked, and realistically, there's often nothing wrong. That is not a good use medical system, right? And in my experience, I see much more of that from self-care than the super, thank God we did this, we just saved a life from self-care. Now, that is all the concerning side of things. I want to, if I have time in a second, I want to just mention the genetic testing side, the 23andMe type testing, and how we sort of can get ourselves into trouble there too. But I need to mention now the fact that I think everything I just mentioned is a short-term problem. It's what I see now in 2020. It's probably what we will see over several years, but I don't think that's the end of where self-care would take us. I believe as we accumulate all of this information from all of these patients who are in some ways getting information that's not very useful to themselves, but if we can use that information through artificial intelligence, machine learning, and having information on patients, whether it's healthcare, mental health information, cardiac information, or otherwise, on a large series of patients, collecting that information, which we currently don't have, will get us to the better algorithms, will get us to only seeing a doctor or a healthcare professional if you really need to. And that is where I see major positives. And I actually think it's inevitable, except there's one other thing we have to consider: privacy. You know, when you saw the mental health conversations with virtual humans or machines, fine, if that all lives in your computer, no one's gonna have a major issue with that. The moment they know that's going somewhere else to be analyzed, people are gonna have issues. But unless we can guarantee that a lot of this information that's being collected at home is leaving the home to be analyzed in a sort of machine learning and artificial intelligence way, I don't think we're going to make progress. And yet, how do we convince people who might be okay chatting with their physician or a nurse about their medical problems to allow information collected on their device to go into sort of the ecosystem? I think people trust their doctors and nurses probably more than they trust Google with their info at this point. I actually see that as a significant issue for us getting to that better place. But again, I'm going to end with optimism. This is all very exciting. I think we will get there if we can consider all these issues up front as we think through the technologies we want to spread out into the world and have our patients use. So with that, I think I've passed my time, and I will, I guess, look forward to the question and answer session.
Thank you so much, Yaniv. You did, it's perfect. So there have been some questions that have been answered already, and there are several open questions in the chat. And most of these have to do with Plan C.
Most people, once they start the procedure, have already pretty much made up their mind. There's not that much people who, not many people who take the first one and regret or change their mind and don't go on. More likely and much more prevalent is taking the second pills and then the bleeding not happen, and then wanting to know what they need to do next. You know, what the impact would be in terms of what happens if you only take the first one. One of the things I mentioned is that more and more we're finding that as people know about this, they're taking these pills earlier and earlier in gestation. They're coming. I mean, the providers have been just shocked because sometimes they don't even know how the people know they're pregnant because it's so early on in gestation that they want these pills. And in that case, just taking the first one is usually enough to start the bleeding. So I think that a focus on what to do about, you know, there's been a focus by the antis to try to make this whole thing about how you can reverse a medication abortion by, you know, stopping after the first one and taking testosterone or taking something else. That is not scientific. It hasn't been, it isn't scientific, it isn't evidence-based, but it's a way of, you know, trying to focus again on a narrative that there's a lot of people who are not capable of having enough knowledge about themselves to know what they want to do, and they're going to regret and change their mind and all of this. So that would be the answer to that question.
Okay, I've got another one for you. Avery Everhart asks, is there, if the hope that is that women is meant to be gender inclusive,
yeah.
Does Plan C work for transgender people who take exogenous?
Yes, yes, so absolutely. No, it's not just a hope, it's very much a focus. Most of the providers we're working with actually have come to this often because they work with transgender folks. And the issue about whether, if you're taking testosterone, for example, for gender transformation, what that impacts on the actual use of the pills is something that people are trying to look into, do studies on. There's so few numbers, it's a very hard thing to study. Most answers usually are, this is a one-shot thing and it's not going to be impacted by the other hormones you're taking. But no, I really appreciate the question from Avery, and really, frankly, it's a huge push to make very clear that we need to serve everyone, and that oftentimes it's people who are transgender who are at the highest need of an abortion because of the kind of violence that comes, sexual violence that might happen that might cause someone to be pregnant that they did not want to be. So we're very conscious of that, and we try to do, and that's why in my speech it's complicated because of politics and because of the human rights, of the inequality specifically around women, and the history of keeping women down around abortion. To drop just using the word women, but we are trying very hard to do that because we want to be all inclusive. So I appreciate that question.
I have one more for you. I have actually two more for you, but I'm going to ask you one more just in the interest of time for now.
Yeah.
What's the future of Plan C in America with the possible nomination of the Supreme Court Justice?
Thank you for that question. And this
Anytime.
it brings me to really how I'm in a way a little bit sorry that I was first, because really a lot of what's happened in the US and what is available is online provision, online purchasing of pills through Indian markets because they've been restricted from us through the normal channels in the US, but also the capability of doing online, using AI, using these opportunities to have just really answer questions and give enough information without using the time of a physician. So it is those technologies that is making this available. And the timeliness of today, I don't know how I sent you in the question and answer an article that appeared yesterday at 5 o'clock as I was trying to prepare my talk for you today. It's changing by the day. Half a day goes by and something comes down politically that's trying to stop the opportunity to make sure that people can have this autonomous opportunity of abortion. A ruling yesterday came down that thank God the Supreme Court, who I really suspected did not want to have to touch the third rail of abortion right now. They want to go for the big kahuna. They want to get Roe versus Wade done ultimately down the road. So in a short answer to what's happened to future of Plan C is more than ever, it's about getting information out. It's about empowering people to know what's available and making it available through something that will not be able to be stopped.
Okay, thank you so much, Francine.
Yeah. Thank you.
In the few minutes that we have left, I'd like to move over to ask Ari. I had a couple of questions. One of them seems to have disappeared, but
I was just typing a response to it. I could just answer verbally if you.
Would you repeat the question, because I thought it was nice for the plenary, and then give a short answer?
Yeah, for sure. Yes. So the question that just came in recently was, is this available to faculty and staff? Everybody needs self-care. And the answer is yes, and kind of. So we were originally funded for students. We have big plans to expand it. There are things that are applicable, like mental contrasting worksheets, sleep tips, and those sort of things. But like college student sleep issues are going to be very different from like my staff sleep issues with a 3-year-old, right? That tries to get into my bed at night, right? So those, even though you can get evidence-based information from ARIA's staff and faculty right now, there are written with a tone focused on students. And we're hoping to expand the project even further so that when you land on the landing page, you let ARI know if you're staff, faculty, or students, so that that literature review of information is packaged in a way that is applicable to your individual situation.
Okay, thank you so much. Thank you to the audience and the speakers. I am going to hand this over to, we still have time. Yes, great, because there's another question that I would love to see answered. And Bill, this one's for you. Tiffany Andelon answers, I like how the artificial human could interact with the people in the presentation. The speaker said that per the study, it showed that people felt more inclined to disclose more personal information to Ari, or to the artificial human, to Ellie, than to a human therapist. The question was, how was that information obtained? Did the study ask people who actually have attended some type of in-person therapy to make that conclusion? And I love the answer to this question, as you know, so take it away, Bill.
Sure. So the way we did the study that came up with that, first, what happened is when we were interviewing people with Ellie, we were interviewing a bunch of people who had signs of depression, basically to train the machine learning algorithms to recognize what kinds of behaviors were indicative of that situation. So we brought a whole bunch of people into the lab, and we happened to overhear them saying, have you talked to the virtual human yet? Yeah, it's really interesting. You don't feel like you're being judged. And so that suggested to us that there might be something going on there. And then we did a study where we set it up so that there was a virtual character that you interacted with. And we told people that in one case, there was actually a human behind the curtain, essentially a Wizard of Oz sort of setup that was controlling the whole thing. And so hearing everything you say and so forth. And then in the other case, we told them that it was all being done by an AI system. And what we looked for then is we had a script that it was following that was asking basically increasingly sensitive questions. And we were looking at how willing people were to disclose. And we found systematically that when people were told that they were in the AI condition, they disclosed more than when they were in the, there's a person behind the curtain who's controlling this. Now, in point of fact, this was a psych experiment, so there's always a deception. And this deception was that both of them were in fact being controlled by a real person behind the screen. But this is what told us that, this happened. We did another study with soldiers who were about to be deployed to Afghanistan, and we interviewed them with Ellie before they were deployed, and then after they came back, and we compared their responses to Ellie versus what they said on a standard paper and pencil post-deployment questionnaire that they get, that all servicemen get when they return, that ask questions like, are you having more nightmares? Are you having sleeplessness, and so forth. And what we found there was that people reported more symptoms to Ellie than they did to the form, even when we made the form anonymous. And I think the element that was going on there was that Ellie, when she asks you a question, she uses a lot of nonverbal cues to try to build engagement with the person. And of course, a paper and pencil form can't do that. The other thing she does is, and this is something that therapists are trained to do, is pose a question and then you just wait and let there be, dead air for a while. And people eventually feel like, I've really got to respond and say something. And so they do. So I think those really the two factors, the use of nonverbal cues and rapport building, and the idea that you're not being judged, those two factors work together to make Ellie more successful in eliciting information from people.
Thank you so much, Bill. Just as a psychologist, I'd like to say that not all of our experiments involve deception.
That's true.
And there's one last question, and we've got 2 seconds to answer it. And if you don't mind, I'm going to answer it. The question is about Ellie. If this therapy turns out to be as effective, by whatever measure, as in-person talk therapy, is there a danger that the profession of talk therapy will be generally automated? I'm going to answer, and Bill, you can chime in, of course. I don't think so. I think that Ellie, or Ask Ellie, or Ask Ari, or any of these kinds of automated self-help therapists will be able to take the burden off the profession and leave the therapists to do the deeper work that can't be programmed.
That's exactly right. That's exactly the scenario of use that we imagine. Much like, before you see a physician, you often talk to a physician's assistant who gets a lot of the sort of the details about your case and then summarizes it for the physician. We see that's very much a role that could be played here, that the system is talking to somebody, maybe noting where they seem to be particularly having trouble, and then giving a quick summary to the physician about what's going on. Also, in a telehealth scenario, we think that some of this technology could also be used as sort of a wingman for the physician. So in a sense, looking over his shoulder or her shoulder and saying, did you notice that your patient, 20 minutes in, really seem to be stressed about this particular thing or that particular thing, and serving as a kind of way to, an assistant in making sure that all the information is captured that goes on in the session.
Thank you so much, Bill. We have taken 2 of your minutes for your closing discussion.
Oh, okay.
So Bill Fordhout, I am my co-director of the USC mHealth Collaboratory. I hand it over to you for taking us out of this great session. And thank you to all the speakers.
Yeah, thank you. So to begin, I'd like to thank everybody for participating, the speakers, the organizers, all of the attendees. I would particularly like to thank Shervan Sebastian, who is kind of our unseen Zoom expert behind the scenes, who is providing all the technical support and making things work as well as they did. Thinking about self-care and health, I think, which Laura did a great job of defining at the beginning. I think, in a sense, we're at roughly an analogous point to where the internet was maybe back in about 1998. For those of you who are around back then, you may recall that it was a time of a lot of optimism. The internet was seen as a breakthrough that could make lots of information readily available at our fingertips, give people a platform to express themselves, revolutionize how we consumed media and interacted with each other. Now, a little over 20 years later, while many of those hopes have actually been realized, we've also seen the unintended consequences of largely uncontrolled development. And the darker side of the internet has emerged with examples that are in the news every day, ranging from issues surrounding loss of privacy to cyberbullying. And the internet has emerged as a fertile ground for misinformation and disinformation campaigns, with social media sites that have recommender engines that actually, in many cases, serve to increase division and discord rather than bringing us together. So this, I think, can serve us as a sort of cautionary tale. Right now, self-care and health has tremendous promise, making healthcare more accessible, lower cost, using device sensors to provide healthcare givers with a more accurate pictures of what's going on in their patient, or even using virtual humans as kind of an interviewing capabilities, as we've seen. But just as with the internet, the promise of these new technologies also, I think, raises important ethical concerns as we've begun to explore today. That's why I think seminars like this are so valuable, and I would really like to thank the organizers for putting this together. I think we really need to take these, potential pitfalls seriously, because only by doing so can we hope to avoid some of the problems that we've seen in the past. So thanks again to everybody for participating, and to the attendees. We hope that we've been able to provide you with some food for thought. I'd like to say thanks very much for attending.